Good evening, everyone. Now, did none of you go to Catholic school? Now, we'll try that again. Good evening, everyone.
Good evening.
Thank you very much. Wonderfully done. Okay, before we move on to introductions, I'd like you to just take a look at this slide. This is pretty exciting. Local food market on the quad with Tallulah's Tacos. I mean, who could ask for anything better than that? So you may want to check that out. Someday if you're not here at the university all the time, you may want to make a special trip. So, I would like to welcome you. By the way, I'm Judith Swift. I'm the director of the Coastal Institute. Now, you might ask, what possibly does Judith Swift have to do as the director of the Coastal Institute with a colloquium that's focused on healthcare? Well, I will point out to you, not to divert the panel to a new topic, but I will point out to you that one of the things that we are dealing with is climate change, and climate change is going to have an enormous impact on healthcare. It's going to have an enormous impact on health, and so it's something that we are deeply concerned with, and it's something that a great deal of attention is being paid to. So I do want to welcome you to the 2012 Honors Colloquium, Healthcare Change, ? Health, Politics, and Money. Now, first, in the interest of health, and those very precious organs that handle this part of one's bodily functions, I would like to tell you that restrooms are located in the lobby and downstairs. House right, that's your right as you face me. That's called house right. This is called stage left. I'm giving you a whole bunch of useless information this evening, and then they'll look even better by comparison. So, before we jump into the panel, I also want to note that there are exits, which were the entrances. And you are going to also notice that we have 2 exits that are down here on either side, and there are 2 exits up to your left and right inside the auditorium, plus, of course, the exits that go out from the doors where you entered. So should there be any reason for you to need to exit, there's your options. Okay, I want to mention first about what's coming next week, which is a pretty extraordinary event. And I'm going to mention it now because I know a lot of you are going to be running out to get in your car and get to the town hall meeting that's happening this evening. Next week will be Roberta Friedman, who is the Director of Public Policy at the Rudd Center for Food Policy and Obesity at Yale University. Prior to her work at Rudd, Ms. Friedman was the program director at the Massachusetts Public Health Association, where she coordinated efforts to pass legislation to improve school nutrition. Dr. Friedman discusses how to educate policymakers on the science supporting the food and nutrition policies that have the potential to create real change. That is on October 23rd, next Tuesday, same time, same place. Now, it is my distinct pleasure and honor to introduce a longtime friend who I admire deeply for her integrity, which has stood the test of the political sphere. And as we all know in this election season, that's no easy job. Elizabeth H. Roberts made history in 2007 as the first woman in Rhode Island elected to the position of lieutenant governor. She was re-elected to a second term in November of 2010. She previously served in the Rhode Island State Senate from 1997 to 2007. And throughout her career, she has been a respected leader in healthcare reform. I would actually add that she has been a passionate leader and defender of health care for all Rhode Islanders. She's also been a small business advocate and the state's disaster preparedness leader as far as any efforts to deal with such issues is concerned. Currently, she serves as chair of the Long-Term Care Coordinating Council, the Small Business Advocacy Council, and the Emergency Management Advisory Council. In her work on the Long-Term Care Coordinating Council, Roberts has pushed to expand community-based care for seniors and people with disabilities. In January of 2011, Governor Chafee signed into executive order the Rhode Island Healthcare Reform Commission and named Lieutenant Governor Roberts as its chair. In this position, she leads the state's efforts to implement national health reform with the triple aim of improving quality of care, the health of the state's populations, and reducing health care costs. And I will tell you also that she is well prepared to handle a task of this size. She graduated from Brown University in 1978 and earned an MBA in healthcare management from Boston University. Before serving in the Senate, she worked as a business strategy consultant, policy analyst, and healthcare manager. Ladies and gentlemen, she is truly one of Rhode Island's treasures. And I give you now Lieutenant Governor Elizabeth Roberts.
Thank you, Judith. I always feel when somebody does a bio like that, I should walk on water up to the stage. I truly appreciate it. It is in the good Rhode Island tradition that I think I've known Judith, well, far longer than I've been in public life, that is for sure, and have enormous respect for her as well. She's very good at the stage left, stage right, and I miss her directing. I am honored to be here tonight, and we have an interesting discussion, and health reform, as you heard, is one of my areas of passion and interest and leadership in our state. And it is clearly a national issue, as when you rush out tonight, for those of you who are to listen to the town hall, I have no doubt that this will be one of the topics that's being discussed at the national level, as it has been over the last several years. I do want to tell you that we are going to try and finish a little early so that you can stay here until the end and still get home to watch what should be a fascinating evening. But one of the most important things, and I think misconceptions about national health reform, is that I think many people think that somebody in Washington is developing a whole new system, and we're all waiting, and when they're done, we're all going to do what they tell us. But the reality is that the law that passed a few years ago really says to the states, here are some rules that are pretty vague, actually. Here's a lot of money, which we in Rhode Island can use, and we want you to transform the healthcare system. I actually wish they'd been a little more prescriptive than they have been. But the reality is that government officials like me, to some extent, but really the people who are change our system, are the people that you see sitting next to me, or they represent them. They are the people providing care, the people who pay for care, and the people who often are providing, filling in the gaps of what we think our system is. It is a daunting challenge, and the three people that you're going to hear from tonight will bring a very interesting perspective to it. But I think it's so important to realize, and one reason actually we in Rhode Island are doing quite well as we work through some of these issues is that it is the people who are working in the community and advocating at the state level that are helping us do our job. And we have been blessed in Rhode Island, although a few of these people are actually from Massachusetts. But we are certainly blessed here in Rhode Island with the engagement of our medical community, our insurance companies, our government officials, and our consumers as we try and rebuild our healthcare system. So let me introduce the people to my right, who you will hear from tonight. All URI graduates, and you will see some of the very best programs that this university offers represented in the people who are sitting at this table. Immediately to my right is Dr. Joline Macfarlan. She is a board-certified family physician in Fall River, Massachusetts, and is also on the medical staff at St. Anne's Hospital and Charlton Memorial. She graduated summa cum laude from URI in 2001. She's a youngster, with a major in biology and a minor in Spanish, which I'm sure is extremely helpful to her in her work. She received her MD from Boston University and completed her family medicine residency at Ventura County Medical Center in Ventura, California. We were both talking about what then brings you back home, something that seems so powerful for Rhode Islanders. She is a National Health Service Corps scholar, and her special interests include women's health, preventive health care, nutrition, and geriatric medicine, and medicine for underserved populations. To her right is Marie Ghazal. Marie Ghazal graduated with a degree in nursing from the University of Rhode Island in 1977. Yes, I got that right. She's the only one it wasn't in her bio. And I said, oh, we're the same age. It's okay. She has spent over 35 years dedicated to improving health care and reducing health disparities for Rhode Island's most vulnerable residents. Through her accomplishments as a registered nurse, health center director, administrator, and now the chief executive officer of the Rhode Island Free Clinic, Marie exemplifies a strong leader contributing to the national dialogue on collaborating to improve care, community partnerships, and a healthy, robust, cost-effective healthcare delivery system, particularly for those who have limited access. As CEO of the Rhode Island Free Clinic, she leads the clinic's volunteer provider community partnership model. The mission is to provide high-quality medical care and preventive health services to Rhode Island adults who do not have health insurance or cannot afford to pay out of pocket for those services, and to serve as an educational site for trainees in healthcare fields. Care is provided through a dynamic statewide network of volunteer medical providers working with academic, medical, and community partners. To her right is Dr. Keith Lewis, who also has a degree in pharmacy from here at URI. He is professor and chairman of the Department of Anesthesiology at Boston Medical Center. He graduated from URI in 1976 with both his bachelor's and his registered pharmacy degree. I keep forgetting about the different terminology around pharmacy. It's changed over time. And went on to receive his MD from the University of Connecticut in 1984. He completed his pharmacy residency at Yale New Haven Hospital. He completed his residency in anesthesia and his fellowship in cardiac anesthesia at Brigham and Women's Hospital in Boston. Beyond Boston University School of Medicine, Dr. Lewis has taught at Harvard Medical School, Yale University School of Nursing, Fohn School of Dental Hygiene, and the University of Connecticut. He is the founder, vice president, and a board member of Plexus Management Group, which is a consulting service and practice management organization that identifies and solves the technical, operational, and strategic challenges that face hospitals and physician groups. None of the people you're going to hear from tonight has a particularly simple job, as those biographies described. Healthcare is a complex industry with complex issues and very personal issues. So you will hear about the business of healthcare, but also the human aspect of healthcare. And if we forget in our work how important both sides of that are, we will not be successful. So I'm going to turn first to Marie Ghazal to ask her, because she is really the safety net for the safety net in many respects. What are the major unmet healthcare needs of clients that you see in the Rhode Island Free Clinic?
Thank you. The Rhode Island Free Clinic is an amazing place. I want you to picture this. The patients that come to the clinic, they can be your parent, they can be your neighbor, they can be a family member. They are really the working poor adults, uninsured adults of our state. People that have lost their jobs, people that cannot afford to pay for health insurance. I can tell you a story. I can tell you a story of a man I saw last week who is a salesman from Bristol who had surgery 4 years ago for a tumor that was pressing on his spine, and who lost his health insurance, continues to work as a salesman, but for the past year and a half has been unable to perform his job because he has pain down his legs and in his arms, and he's using a cane. Picture this person waiting at the Rhode Island Free Clinic in our lottery system to get an appointment for health care, to become a patient of the clinic. He talked to the doctor that did surgery a year ago and was told that he needed to get an MRI and he needed to get health care. So he researched the Rhode Island Free Clinic on the internet and found this is a place I can go that could help me out. So that particular individual was selected that evening to become a patient. So that individual was able to get an MRI, was able to be seen by a physician, and was able to basically get help so he could work like you or I do every day and he was able to take care of his family and do things that we want everyone to be able to do. We see patients at the clinic who can't afford medication. So for a small cost, we can provide them with medications and we can provide them with care so they can take care of themselves. We see people that had heart surgery a few years ago and can't afford to pay for the blood thinner that they need to take, so we can get them into care. We see people that have diabetes, many chronic conditions. As I said earlier, the clinic is there for the working poor. It's to help people who have fallen through the cracks. As the Lieutenant Governor mentioned, we're the safety net for the safety net. And we cannot forget about that population in our state. So those are the types of people that we see, and every story is a life. Every story is a story that, as I said, could be someone you know. It could be someone that you know that lost their job. So the stories, I talk to all the patients, I hear all the stories, and it's really a main reason why I continue to work at the Free Clinic, because we have to work towards everyone getting health care. We shouldn't have people without their medicines or without the care that they need to take care of themselves. So that's what it is.
Thank you. So as I mentioned in their biographies, both Drs. Lewis and Macfarlan practice in Massachusetts. Most people are aware that the new national law we're implementing is very much patterned on the law in Massachusetts. That we now have, as Marie was describing, the stories of people who are uninsured, somewhere between 120 and 140,000 Rhode Islanders uninsured in our state of 1 million people. And in Massachusetts, that number has declined significantly under their law that was passed now 6 years ago. But if each of you could take a moment, I'm going to turn to you first, Dr. Macfarlan, because you're right next to me, to describe the impact of the Massachusetts law on your practice and what you see, both from your perspective as a physician and how you see your patients impacted as well.
Absolutely. So I've actually been practicing back in Massachusetts for just about 2 years now, a little bit over 2 years. So essentially, Massachusetts healthcare laws is the only law I've practiced under. I did do my training at BU and then went to California for a few years for training. So I came back to this kind of new world of medicine. One thing that I noticed, comparing my work in Massachusetts to times before that, is I don't have to make what kind of insurance coverage a patient has one of the first questions on my mind when I walk in the room. I can think about that person, their health care needs, their social needs, before I look at what type of coverage they have. Because things are really a little bit more even across the board. A lot of different medicines are covered that in the past might have been more variation. It's easier for me to get people into the specialists they need to see, or to have the procedures done they need to have done. I think it's a little bit more of an even playing field. Another thing that I've noticed is that maybe a lot of people who would have had much more sporadic care in the past are coming to see me consistently and really developing a relationship with me as their primary care doctor. So I think before this healthcare law, people like seasonal workers, construction workers, folks who weren't necessarily in the job for years on end with the same benefits, didn't tend to have established relationship with the primary care doctor. They'd get care when and where they could, and a lot of times that changed based on their insurance situation. Young people under 26, now everybody up to age 26 is covered or has the opportunity to be covered under their parents' health insurance. So that's a population that absolutely has more regular access to care. It's such an important time in people's lives. You're developing your adult health habits. It's a great time for a primary care doctor to make interventions about quitting smoking, maintaining a healthy weight. So for young people to have access to primary care in a more consistent way, I think is a huge change.
So, Dr. Lewis, you have practiced in Massachusetts both before and after the healthcare law that passed in the mid-90s. Or, I'm sorry, in the mid-2000s. I've lost a decade there. I would be very interested in your perspective.
I think for those of you who can see it, for current events in Massachusetts, in the Boston Globe, there was an article from September the 8th, and the title of the article is, "With Profits Down, Future of Massachusetts Hospitals Questioned." And I'd say that since I practiced medicine in Massachusetts since 1992, we as physicians in hospitals in Boston have been trying to decide which hospital would close. And so we've been focused on that for almost 20 years, and none of them have closed. So I think our ability to self-contain or not have 5 level 1 trauma centers in one city, it's not been very good at cost containment. So what I've really seen is that we've seen an amazing amount of anxiety among the hospitals. One of our networks, for example, Stewart, has just proceeded to buy many different hospitals, one of them being St. Anne's Hospital. And there are a large group of hospitals now that are really looking to take community hospitals into their network. So what we're seeing is a lot of hospitals trying chair rearrangements of who will be our partner, how will we do things differently, and will we survive. What I'm reassured to see in Boston is that people are starting to look more at integrated care, looking more at creating good health as opposed to treating bad health. So it's a whole concept change, I think, that's going on in the Boston market. I think all of us are realizing, and certainly the politics in Massachusetts are fairly robust in healthcare reform, that we're looking now at how can you move some of the high expensive services you do in tertiary or quaternary care hospitals to the community. And I'd use in Rhode Island the example of not far from here you have South County Hospital. So our charge would be, how can someone that has sepsis, a life-threatening disease state, or pneumonia be treated just as well, if not better, at South County Hospital as opposed to one of the academic medical centers in Providence. So I think there's a big movement with different types of monitoring, with telemonitoring, where we have virtual ICUs now in Massachusetts, with UMass having something called EICU, which allows a doctor in a particular room, could be right here behind this curtain, with 3 critical care nurses watching all the hospitals in their network to make sure that in all those hospitals, each patient receives the high level of care. The goal here being providing that level of care at a much less expensive hospital, such as South County, Westerly, or others. So I look to say that we're starting to reach out as academic medical centers, and I think healthcare reform, and I think what the Lieutenant Governor said is really true, is we can either wait and see what's going to happen, and I think what we're trying to do in Massachusetts is really determine what will happen to us. And I think that one thing that's not happening, and it's probably something that all of you are fearful of, that the quality of your care will go down. And I think the one thing that we can say unequivocally this evening is just because it's expensive doesn't mean it's perfect. And I can speak of the Boston market that sometimes doing less is better. Fewer drugs, fewer operations, fewer visits to the hospital. So the real moves that we've seen in our hospital is trying to move some of our services to the community, reaching out to elders that have congestive heart failure, providing their care at home or in their house, not waiting for them to come to our emergency room in congestive heart failure, but instead going to their home 1 or 2 or 3 times a week to make sure they're on the right diet, they're taking their medications, to look at their pills, to make sure they're ambulating or doing those things to promote health as opposed to illness. So I think what we're really trying to do as a hospital is to keep people out of the hospital. And that's a very different goal. And the real struggle for us in Massachusetts is to get away from a fee-for-service model where we're paid to do things, but instead to look for an affordable care type model, or an ACO type model, where patients are grouped into a particular system and receive a certain amount of payment for them, and we among ourselves as a team of nurses, physicians, pharmacists, physical therapists, and others really determine what we need to do to our patients to keep them healthy. Because the market now is you come to our emergency room whether you need to or not, and you receive a certain level of care, and unfortunately our hospitals and ERs are crowded with patients that don't really need to be there. So what I'm really seeing in Massachusetts is we're really trying to make sure people get care in the right place. And the right place may be your home, or it may be a community hospital and not an academic medical center. So you don't have to go to Boston to get your heart fixed. You can do the same thing in Rhode Island or other locations, but people think crossing a border or going to a different location like New Haven or Boston may be the answer, but you in Rhode Island have an amazing system that if you put it all together and made sure you have the right services that was integrated and you communicated effectively, you can provide very high quality care at the best value and perhaps the lowest cost. So I think you in Rhode Island have an amazing opportunity because you're not a Boston with 5 level 1 trauma centers, all within 1 mile.
Right.
And we all do 500 cases as opposed to one center doing 2,500.
Right. So you actually used a term that I think would be really important to kind of talk about, define and also talk about as you've seen it, and I know that Dr. Macfarlan is involved as well, and that is accountable care organization, which is something included in the national law. We have a number of accountable care organizations existing in Massachusetts. We have one that's not hospital-based but is primary care-based in Rhode Island. But I didn't know if anyone would like to describe for people here what that really means and how is that different from some of the things that patients and consumers weren't happy with 20 years ago when you think about the HMOs and managed care. Does anybody want to take on the challenge of describing an accountable care organization and what it means?
I'm an anesthesiologist, so we're probably the least attractive entity, as well as a surgeon in an accountable care organization, because what you're trying to do is control cost. And what we do, meaning the OR, is we really drive cost up. But my concept, and I like the concept of an accountable care organization, is that you have a group of people that work together. They're accountable to their outcomes, so you're completely transparent. Information can be seen and viewed by others. You provide care, which is important, and it's an organization which implies that you're together. Unfortunately, in Boston, the word silos happen. We have the Massachusetts General Hospital, we have the Brigham and Women's Hospital, we have the Beth Israel Tufts, BMC, and several others, and we don't all communicate with each other, and costs are often higher, even with partners being a conglomerate of 2 hospitals still together. Their costs have really gone through the ceiling. They're struggling. So what we're going to try to do is to get all these silos of cardiologists, primary care doctors, and others all to function in a way and really think about the health and well-being of a patient population as such, as opposed to a patient. So we're looking at grouping. So I may be responsible for a certain segment of the population of Rhode Island in my ACO that I take care of, and I really control my cost and my destiny, which is a very different system that I, as an anesthesiologist, get paid at this point in time by you having an operation. I may in the future get paid by you not having an operation. So what it's doing for us, many of the specialists, is that I should be involved with your care from teaching people in the community about how to avoid hip fracture as an anesthesiologist, or calling you a month after your operation to see how you're doing, to see what things we could do differently moving forward in reference to perhaps pain control. So I think a lot of us are becoming much more diverse in what we do and broadening our base of practice so that anesthesia is no longer, for example, an operating room sport, but it's something that's more of, we're involved with pain control, we're involved with intensive care unit, and we will together, as practitioners, work together to take care of a population of patients really to avoid health care issues in that patient population. So it's a very different approach about prevention, avoiding harm, avoiding unnecessary testing, and doing the right care in the right place at the right time. It's really what we're looking for as we move forward.
Did you want to add anything to that, Joline?
I guess my definition of an ACO, or how I understand it, would be that Medicare takes a group of patients, is a defined group of Medicare patients who belong to this ACO, and kind of enters into an agreement with a healthcare organization to say, well, we'll give you this amount of money per member per month or over this amount of time, and if you can meet certain quality benchmarks, and there's a whole list of them. For diabetic patients, are their sugars at a certain level? For people with high blood pressure, is their blood pressure controlled to a certain level? Are a high enough percentage of patients getting their colonoscopies and breast exams and PAPs and all these preventative services that we aim to offer? And if we can do that, meet those quality measures, and save money, then we come out ahead. If we don't spend more than we were given, we've essentially had a successful relationship with that ACO. That's my kind
I think there is a huge change going on that's really moving away from how many times you see or treat a patient to really how do you help to manage that patient's care. For those in the audience that don't know, actually South County Hospital is not an ACO but has an innovative contract with Blue Cross that has some very similar characteristics. So they are paid based on some quality outcomes. They are paid basically a standard amount, and if there's anybody here from the board, you can correct me if I don't have all the details right. But it used to be you were paid based on how many beds were full. So in an odd way, you wanted people to be sicker and in your hospital. Now they're being paid the same amount no matter how many people are in the beds. And it has changed a lot of the business practice. Luigi and Cola has been doing a great job. You now have doctors going out and treating people in nursing homes, which is something you generally have not seen in a long time. Much stronger relationships with a lot of physicians in the local community. So you're going to see more and more of an approach that says, how do we help to manage the population of a community? But I'm also know that, and actually I'll turn to Marie, because one of the things as the safety net for the safety net is you also see you're trying to coordinate care in one of the toughest of situations. But I think all three of you can talk about how difficult it can be to break down those silos that have built up over time, and how we can build communication, particularly using information technology to help our patients. So I didn't know if you had any insights you wanted to share, Marie, about
well, I think I wanted to add a little bit to the previous question about the Rhode Island Free Clinic, and the goal is to really improve people's lives. The goal is to make sure they get healthy, just like we're talking about with the accountable care organizations. So, you know, we charge no fees. You can see the nurse. You can talk to a nutritionist. You can join an exercise class. You can attend a cooking class. The goal is for you to improve your life, to get well. And that's what we see with the patients at the Rhode Island Free Clinic, because it's not just, we don't bill. It's not just about coming in and spending so much time with a doctor or a nurse practitioner. It's really about doing whatever we have to do so that person changes their behavior. And picture this. People want to change their behavior. They want to make themselves well because they're desperate. They have no health care. They're desperate because they have limited resources. They're desperate, so they do whatever they have to do. We have patients that are newly diagnosed as diabetics who after 3 months, 4 months, they lose weight, they change their eating, of how they eat, and eventually they don't even have to take medication. So that's really should be the goal of healthcare. It should be to get people healthy, and it means that we have to do, you know, I think about, you know, years ago when I was at URI in the nursing program, it was really about many of the things where you know, that Keith mentioned now about home visits, about educating people. It was about putting those resources, having those resources available by all the disciplines that we need to, so that we educate people better. Because if people take charge of their health, then we don't need all the emergency room visits, and we don't need, you know, all of the you know, the medicines and you know, all the things that happen. So that's really what we do at the Free Clinic. I mean, we serve 2,000 patients. We're not serving, you know, huge numbers of people, but for those 2,000 lives, we change their lives so that they will be healthy and they will be productive members of, you know, society. So as far as, did you want me to mention about the IT? We do use an electronic record at the Free Clinic, and the future is really for us to have, you know, to really maximize the electronic system, so that, you know, our patients, if they're in the emergency room, if they have a test, that we're able to see that, so that we really reduce costs, because we're not duplicating. We're not duplicating unnecessary tests and unnecessary procedures. Or we're not making the wrong decision because we don't have the right information about a patient. So the future in Rhode Island, and I know Lieutenant Governor has championed a lot with you know, the electronic records and the health exchange and many things that we're doing in our state. You know, we need to continue to do that so that that care will be more affordable, and it will be accessible, it'll be high quality, and that's what the electronic, you know, medical records and the health exchange will do for everyone, including the, you know, the uninsured.
Yeah.
Okay.
So before, in a few minutes, did you have something you wanted to add,
I would like to add, yeah.
Please do.
So I think electronic medical records have made a huge difference in kind of keeping the communication. We're talking about medicine or healthcare being much more team-based, and a lot of different people involved in keeping people well. So it's helping that communication to be closer to real time. I wouldn't say that it's perfect yet. There's still this issue about, I'm using one computer system at the clinic, but then the hospital has a different one, and the lab has a different one, and there's an interface, but there's a lag, and the systems don't always talk to each other. I think IT is really exciting in terms of different ways to communicate with patients. I just read an article the other day about a pediatrician who has a separate work cell phone, and she uses that to text with her adolescent patients. A much more accessible way for patients to be able to get in touch with her rather than having to call her front desk, leave a message with the secretary, wait for her to call back. That's not how people operate anymore. So, improving patient care. I email with patients.
Right.
Another
I think it's often hard for people who are outside. I mean, we still realize, actually, when we think about it, that most of our doctor's offices, they still put that paper chart in that little plexiglass thing on the outside of the exam room. And when you think about the fact that I've got a card right here that I can walk into a ATM in Rome, and it can tell me how much money I have in Citizens Bank here in Rhode Island, but you can't walk from your doctor's office across the street to a hospital and have them know that information necessarily. We have profound changes coming in healthcare and needed that will make that information follow you or me through our healthcare system. Not uncomplicated to do, and not always in the financial interest. So much of what we're doing here is really how do we align financial interests for people providing care, people paying for care, and those of us who need to use it, because we should really be driving what happens, the quality of care that we receive and the timeliness of that care.
I think another important point is that, with electronic records and with access to your information, it's your patient information. We're hoping that it will empower people to take more responsibility for their own health. If you know your labs, if you know your tests, when you interact with your doctor or nurse practitioner, you really know what's going on, and you can help that person so that things aren't duplicated and that care is better. So it will help, I think, an important area in the future, and also to contain costs and to really help people get to optimal health, is people have to take responsibility. And I know at the Free Clinic, if people don't take responsibility, it's not just about having a medical visit. It's about, are you going to meet with a nutritionist? Are you going to follow what you have to do? Are you going to look at how you're going to add exercise to your life? If they don't take the responsibility, then they really almost don't become a patient of the clinic. They have to take the total responsibility, because it's more than just a one-on-one visit with a physician or a nurse practitioner. And I think the electronic system will really help to ensure more responsibility for people.
So, but, I'm sorry.
I think a lot of it's about, it all comes back to how do we make decisions about what to do, and it's all about creating a patient-centric or centered environment of how do we help you at a time that you're incredibly vulnerable, whether from a financial standpoint or a coverage standpoint, or I'm scared to death about what could happen to me and what is about to happen to me, that how do we expect you to be engaged in your decision at a point when you just want to say, just do what you need to do to make me better, and you may not fully understand the consequences of that, and that's particularly true when you talk about high-intensity procedures of heart surgery, liver transplantations, other things that cost enormous amounts of money that, we're now developing tools by using, automated systems of how to give you the information that you need so that when you leave, you can digest it. We can really ask you, is this what you really want as you move forward, as opposed to, here's what I recommend. And unfortunately, in certain situations, patients may end up with algorithms of treatment that may not be what they wanted, or they didn't think the consequence would be a certain direction. And they said, if you'd only told me that, I would have done something differently, a less invasive procedure, or I'll do weight loss as opposed to bariatric surgery. Because patients think of words like bariatric surgery, and one of the parts of the Affordable Care Act is that there are a lot of pilot projects of pediatric, obesity. And I said this afternoon at the the session with the students that I see patients all the time that are 14 years old that weigh 400 pounds. And is the answer to their illness bariatric surgery, which changed their whole eating pattern for their entire life? Did we do a service to get to that point in time where that person needs a very invasive and a big operation that has total long-term consequences? So most people that have bariatric surgery don't really realize that it's not like I'm better and I'm never going to gain weight again. Your whole eating pattern and life changes at that point in time. You become incredibly dependent on an operation that makes a big change. So I look to say, I think where we failed as a healthcare system is we've not educated people about what's the right thing to do as opposed to what is often the easy thing to do. And operations are easy, and drugs are easy to take. It's much more difficult to change the behavior, which I think we're looking for as we move forward in affordable care type activities.
So before we go to questions from the audience, I'd like to ask each of you to fairly briefly say, what is from where you sit as a professional in the field, what is your greatest hope and or fear for our healthcare system, particularly at this time of enormous change? Keith, I'm going to start with you.
Hope that we get safer. My whole career has been based on safety. From my pharmacy, I was involved in writing a book on cancer chemotherapy before it was popular to talk about patient safety. The founder of my anesthesia group founded the Anesthesia Patient Safety Foundation in the 1980s, which started the revolution. I can speak and say that in 1950, if you had anesthesia, your chance of dying was 1 in 50. The chance of dying in the year 2012 from anesthesia is about 1 in a million or more. So we've become incredibly safe. So safety's come by standardization and working as teams with nurses and other physicians. I think that we're a group that gets it. So my biggest fear is, can we break down those silos? Can we become united? Can we train people differently, meaning nurses, pharmacists, physicians, assistants, to work together as a team, realizing that it's not built about a person, it's built about a system. So the question is, how quickly can we do this? My biggest fear is, do people have the appetite, many of those physicians in the group, to really change the way they practice now, to realize that teams function better, and our number one priority in medicine really should be safety and the way we take care of our patients.
Marie?
I guess my mission and the point I'm at in my career right now is to ensure that everyone has access to health care. That I don't have to look in the eyes of people that are desperate or don't know where to go or can't afford it, even though they have insurance, they cannot pay for their medicine, so they haven't picked them up at the pharmacy. So I really hope that we have, it's a right for everyone. I hope everyone gets health care, and I hope it's the type of health care that I've spoken about that really gets to helping people and educating them and having them change their behaviors, and not just health care that, is surgery once you're, if you're a diabetic, dialysis, paying for their dialysis. No, we should be paying for them when they're 30 or 40, before their diabetes has become severe, to help them with educating. And our healthcare system needs to reimburse and needs to have incentives so that we can reimburse nurses and nurse practitioners and all the members of the pharmacists and all the members of the healthcare team that play an important role to educate people. And, that's what I hope, that's what I envision, and I think we've made great strides in our state, and with the Affordable Care Act, I think that's great. We'll move towards more access, but we still have a ways to go.
Yeah, I think I need to echo what Marie said. My hope would be that these political changes help even the playing field, that everyone in this country has access to the appropriate care at the appropriate time, has access to preventative services that are proven and recommended. I teach a course here at URI, a women's health course through the Gender and Women's Studies Department, and one of the things that we talk about a lot is the medicalization of normal human experiences. So, we have a really long history of pharmaceutical industry influence on healthcare, and Americans tend to take a lot of pills compared to the rest of the world. My fear is that, as this becomes a bigger process, that more people will end up taking more pills, And I hope that the focus of everybody having access to more care is really preventative care, wellness, and not just taking more medicines for normal human experiences.
Great. Well, thank you. So now I think we want to turn to questions from the audience.
One of the first questions for the panel: as patients and providers, do you see the need for a patient's bill of rights? Is this politically viable in the short or long term?
I'll go.
That's for everyone.
Yeah.
Anyway.
So the Patient's Bill of Rights, as part of the Affordable Care Act, really had to do with some pretty abusive practices within the health insurance industry. This is the part of the Affordable Care Act that talks about getting rid of lifetime limits and people not being disqualified from insurance for pre-existing conditions, things like that. So yeah, I think absolutely it was an industry that needed some regulation. These are all really reasonable things. There's plenty of examples out there of people who really could have used this Patient's Bill of Rights and who suffered or died because it wasn't out there. Is it politically viable? I guess we'll see.
Other questions we want to
Sure.
bring up?
Please comment on last month's Institute of Medicine report on the reported $750 billion waste in 2009 in the U.S. healthcare system. What are some ways to reduce this waste? Is the ACA part of the solution?
Well, I know I read the report, and I think it said that for every dollar, I think 30 cents is wasted. And I spoke earlier of the things we see every day, of how there's unnecessary tests, there's some inaccurate information sometimes that patients have and give to their nurse practitioner or provider, and it causes unnecessary treatment. And the ACA is really aimed at also talking more about prevention and about testing and many preventative measures. So, I think that we can't continue to spend what we're spending on healthcare and getting what we're getting. And in Rhode Island, we can't continue that as well. We need to focus on what I was saying earlier, more of the preventative on patient responsibility and the accountable care organizations, and really looking at trying to work towards getting people healthy, because we have the highest costs and quality. I know safety's been mentioned. When you really look at what's happened to the healthcare system, we've all had experiences that we know could have probably been a little bit better, and we have to get to that, and we really need to do it, because all of our insurance premiums and all the costs we're paying for all the tests that we have, they're just continuing to rise each year, and it's going to be unsustainable.
I think that when you look at the Institute of
Right.
Medicine's report, that what they're really asking us to do is to really create a culture of kind of continuous improvement. And one of the biggest problems we have in healthcare is that we have these amazing pockets of excellence. Denver Health, Geisinger, Proven Care, where in Geisinger, when you have cardiac surgery, they've decided that there's not a single thing after cardiac surgery that a patient should miss in reference to what's been proven to improve their outcome. So it's whether taking an aspirin to prevent a stroke, or taking an anticoagulant to prevent funny heartbeats that can happen after cardiac surgery, or having visits at home to make sure you're taking your medications, to check your wound early to make sure you don't have an infection. That Geisinger's, kind of like car warranties, where cars warranties used to be 10,000 miles, 20,000 miles, 50,000. Now everybody looks and says, how do I get the one for 100,000 miles or the lifetime of the car? I think that in reference to Geisinger with cardiac surgery, they said that we will guarantee you then a reference to the following things. If anything happens, you come back and we own it. So there's not an additional fee if you developed an infection and need another operation. And an infection in a cardiac patient, just to give you a perspective of cost, if you have an infection in your sternum after the operation, which can occur, diabetics are more susceptible. If they use certain blood vessels, you're more susceptible. The cost of a hospitalization for an infection after that operation is between $30,000 and $50,000. So there's a real motive to prevent it besides the discomfort to the patient. There are well-proven techniques of what we need to do. So what right do we have as healthcare professionals providing care to send you away without the adequate tools to make sure you do what is 100% right in order to minimize the risk of infection, whether it be our use of antibiotics in the OR. So another important part of the Institute of Medicine report is really about transparency and feedback, and really trying to also target certain patient populations, diabetics, asthma patients, congestive heart failure patients that are known frequent flyers of emergency rooms because they often have relapses. So I look to say, how do we keep those patients out of the hospital? And I think the Institute of Medicine report is really going to require us to not only do it ourselves, but as I alluded to before, the whole concept of shared decision making, of how do we, with the patient, work to make sure we do what's best for them. Because unfortunately, the system right now, that even though we have these enormous pockets of excellence throughout the country, not everybody does that. So you may find it hard to believe, but can you imagine if you went on the airplane, every pilot every single day decided he or she was going to use their own checklist? We'd cringe. Pilots can't even fly different airplanes. They can fly MD-80s, but they can't fly 757s or 757s or 787s. They have a standardized protocol, and they have to go through, and it's monitored by Dallas or ground control, that they have to be adherent to that protocol every single time, 100% of the time. So I look to say in healthcare, and there's a lot of talk, and most of you know about it, about checklists with Gawande, that let's look at the impact of a checklist in the OR that only has 20 points. When they went global with the checklist in operating rooms, they reduced mortality in the operating rooms by almost 50%, just by having a checklist. And the checklist means, do you have blood in the room available for this operation? Does the patient have an airway that could be difficult to put the breathing tube in, which is a risk factor? Have you done the appropriate things for their diabetic glucose control? You may say, well, that's an impact in the rest of the world where they have problems with quality and outcomes, but the mortality at the Brigham and Women's Hospital on 75 Francis Street in Boston, Massachusetts, also went down 50% with Gawande's checklist. So if you don't think that we need to do the same things here, and just because our healthcare costs are high, that we're the best, we need to take a really hard look at ourselves. So I think that what the Institute of Medicine is really telling us, that you can take this $750 billion out of it by just doing very good quality, high proven practice. Because now we do a lot of unnecessary things that don't have the best outcomes. So I think that's the cry, and that's what happened 10 years ago in the previous report from the Institute of Medicine, where they say error is human, where we make mistakes, and how we can save 100,000 lives or 500,000 lives or 5 million lives by doing things differently. That once again, we're looking at how do we create a momentum in every state, across the United States, to do a better job. And that's really the challenge to us as we move forward, and those in the crowd that are going into healthcare moving forward. So it really is your charge, as we move over the next 10 or 15 years.
And I think the integration of information technology is going to be huge, because one of the reasons we have waste is sometimes people are forced into it. If you don't have an MRI that somebody had yesterday, access to it, you're going to do another one. You could argue that's wasteful. It is wasteful. We just need to make sure that information can follow you through the system. And it isn't part of the ACA, but it was actually part of the stimulus funding, huge amounts of money for hospitals and physicians' offices to integrate information technology. And the ACA is also, one of the other things that isn't talked about the ACA is there's a lot of funding for individual projects to see what really changes things. So when Heath described a change that made a 50% difference, they're looking for places around the country with an interest and the ability to try things out that then they can take to scale. So we in Rhode Island have applied for a number of grants. Some we've gotten, some we haven't. And around the country, people are doing that to see, okay, how can we make a difference? This works, as opposed to somebody saying, oh, I think this will make a difference. Let's have everybody do it. They're actually saying, we'll give you some money, try it out, and if it works, we're going to try and get more people to do it. It's an interesting approach. Atul Gawande, another article. For those of you in the audience who are health policy wonks, Atul Gawande's series of articles in the New Yorker over the past few years have been sensational. And one was about this approach of sprinkling money in different places with different hospitals and physician groups, non-physician providers who are dealing with public health issues, and seeing what can work. And how do you kind of sprinkle money around and find interesting ideas and then bring them to scale? And he saw that as a really great approach. That is the approach the ACA takes, rather than saying everybody's changing their system in the following way.
Yeah, I think his last article in the New Yorker was, I think, entitled Bad Medicine. It talks about the Cheesecake Factory.
Great one.
And then everybody thinks that the Cheesecake Factory, it's all frozen, sent from California or someplace, but how they prepare in the moment, it really looks at the quality, the efficiency of that center, and why can we not in healthcare really perform at that level. So I think sometimes, to depersonalize and turn it into another industry, whether it be the ATM card, the cell phone, or whatever it may be, why are we so far behind? And I think there are just a lot of stubborn silos that have been traditionally, everybody's independent and does the fee-for-service model. So finally, as a profession, we're starting to look ourselves and dissect out what we can do differently. And that's not easy.
Sorry, Dr. Macfarlan. One really big chunk of that $750 billion, though, I think it was about 180 was administrative costs, excessive administrative costs. So, some of this is even beyond the control of us foot soldiers of medicine, and IT will improve that.
But it's a great opportunity, so I'll do a little government plug, because one of the things we in government can do, so there are some what you would think would be relatively simple things, common claims forms, common sets of rules, so that as a doctor's office you don't have to figure out 5 different approaches for 5 different insurance companies you deal with. And when you look at, we all think about how many people are now non-medical providers who work in our doctor's offices. They're not nurses. They're not, they're actually the people who are pushing the paper, usually on a computer screen. And in hospitals and in insurance companies on both sides, you just have huge numbers of people managing an inefficient system. Just like we are working to do on the provider side, we really need to push. And in Rhode Island, we have a health insurance commissioner, which is a unique position, who has really tried to push some of these issues and been successful. But on the administrative side, we just passed something this year through the legislature that requires the insurers to come together around administrative simplification. Won't be simple, nothing in healthcare ever is, but at least we're setting some goals about how to start to, because that's money that, the last place you want to spend money is on administration.
I have somebody who sits in my office, full-time employee, benefits and everything, who literally, her job is to take the codes that I put in about, patient's visit and the billing codes, print it out, put it into another computer program, because the programs don't talk to each other. So that,
right.
That's a lot of money just kind of being wasted.
So who else has a question?
Well, do you think the reimbursement of doctors needs to be changed in order to focus more on preventative care or preventive care rather than more treatments to gain more money?
Both. No, I think I can speak. I'm a physician.
Yeah.
I'm in the highest paid specialty. Not a good place to be, meaning anesthesia. I don't know why. It has to do with supply and demand, but for some reason we've gotten out of a particular market. I look and say, I don't know why I'm structured the way I am. So I'm looking now to say, as opposed to having a department of anesthesia, this is playing the novel concept, why doesn't every department in a hospital that has surgical patients have an anesthesiologist in the department that's part of their department, that's not part of fees for service, but a very different model? Because now my incentive, or at least the incentive is not mine, but I think it is for many of the people in my group, is the more cases we do, the more money we make, which is so wrong. So I look to say, I'm very interested in the model of, how do we reallocate dollars for programs so we can do education and teaching, because we do so poorly at that. And for us in the OR now, we're becoming much more aggressive in pre-op optimization, as opposed to you go to the pre-op clinic to be told you got an operation and show up at a certain day and time and don't eat or drink and take this medicine. It's like, I really think prior to the operation, you should stop smoking for at least 6 months. You should at least, reduce your, body weight by 15%. And I think you should do the following, and that would optimize you for this operation, because population's getting older. And we used to just look at organ systems, where we'd look and say, your heart's not that good, but we think you can survive this operation. And that's not always true, because you often survive, but then you spend the rest of your life either in the hospital or a rehab center or a nursing home. And that may not be the algorithm or outcome that people want. So we're now looking at things about frailty. Frailty being, hand grafts, strength, that 2 of us may be the same age, but I may be more frail, and there's definitions of frailty, and frailty people spend a lot more time in the hospital and go to rehab facilities about 10 times more than non-frail patients in the same age group. So wouldn't you like to know before you do this, am I one of those frail people that if I have this particular operation, I'm going to end up in a nursing home for the rest of my life, as opposed to an alternate approach that's less invasive, where either I optimize my albumin and my nutrition and my physical therapy and stuff prior to the OR. So I think we're looking at really trying to, with primary care, before anybody goes to the OR, really optimizing our patient populations to do what's necessary, but not to do things that are unnecessary. So I think the whole fee-for-service system needs to go away. I'm certainly not in the majority from a physician standpoint. I think we should work in a collaborative way. I don't understand why primary care doctors make what they make and I make what I make, because they work just as hard as I do and they're just as important to the system. But for some reason, our systems become incredibly distorted that specialists like cardiologists, anesthesiologists, and neurosurgeons get paid enormous amounts of money.
This is really already starting to change, though. My salary, for example, is only about 50% based on how productive I am. How many patients I see and how complex those visits are. The rest of it is based on, a few things, but mostly meeting quality measures. It's mostly things that preventative care is essential for. Things like how many of my patients have had colonoscopies, how many have had PAPs, how many are up to date on various measures. So it's already changing. We already are dealing with a primary care shortage. Undoubtedly, it's in a big way because of the differences in reimbursement between primary care doctors and specialists over the last few decades. That's starting to change. I was lucky enough to go to medical school on a scholarship that, because I was planning to go to primary care, the National Health Service Corps paid for med school, and in return I promised to work in a primary care setting, work in an underserved area. But I can tell you, I can think of a whole bunch of classmates who went into a subspecialty because they had $250,000 in med school loans and couldn't see a way out of it in a primary care specialty. So
I have like 75 medical student advisees, and often the conversation they have with me is, I want to go into anesthesia because I know how much money you make, and that's the only way I can pay off my loan. So, it gets into a whole other conversation of how do we fund medical school education, and, what kind of systems can we develop moving forward to make sure that we have all the people in the right place training together, and money is not the motivation for your choice of specialty, because, I don't think money should determine if someone would be an excellent anesthesiologist that's safe. It's more about motor skills and cognitive function as opposed to loan debt. And when I say it to the poor medical student, they say, I think you should go to Harvard Business School and not go to medical school in this scenario, because you're really not going to achieve what you want to achieve with this particular goal, and it's the wrong motivation. Because, the reason why, in theory, some get paid by more than others is because you generate more procedures and more income, and there's more danger involved. But to me, it just seems wrong, because we're all just providing different types of service that are needed by a patient at a particular point in time.
All right. And I think there's, I want to just add one quick thing, that there are two things going on. One in Massachusetts, where a major law was passed, signed by the governor 6 weeks ago, that really the goal is to eliminate fee-for-service reimbursement. So that will bring some major changes. And the other is here in Rhode Island. We are, in many ways, leading the country around the formation of what's called the medical home, which is a team-based approach. Nurse practitioners, nurses, care managers, it's really, they get additional payment for managing care. So you're starting to see more and more innovation around primary care. And also it's the one of the areas, one of the few, I think, right now, where incomes are actually going up in medicine. I think a lot of the specialists are starting to see a little bit of a cap or even a drop. But we are pushing to increase primary care reimbursements. And our health insurance commissioner is requiring an increasing proportion of the premiums you pay to be spent on primary care services, not on inpatient services. So very interesting. So I know we have another question that popped up.
So the last question, this is for Dr. Ghazal. How do you think the situation of the patients at the Rhode Island Free Clinic will change after 2014? Can you comment on the role that the clinic can and should play after the ACA is fully implemented?
I'm not a doctor, but I'll answer it. And I think it's a really important question, and I am so glad that I've been asked this question, because as Lieutenant Governor Roberts mentioned, there are 120,000 uninsured right now in our state. We know that after healthcare reform is implemented in 2014, the estimates right now are that there will still be 40,000 uninsured in our state. It's really important to understand that because we can't let people fall through the cracks. And places like a free clinic are still going to be important because there are different categories of people that are not going to be eligible for insurance. I mean, Medicaid is going to expand, but there's going to be still a gap of people that aren't going to be eligible for Medicaid. There are going to be people that don't file income taxes and make so little money that they may not be able to afford, that they're not going to be able to afford any health insurance. There are specific populations, people that have religious beliefs, people that are from an Indian tribe. You know, there's the whole issue of people that haven't been in this country all that long but have been here for 15 years, you know, may not qualify for other insurances. And there's going to still be the working poor that cannot pay into what the cost is going to be. So we know that of that 40,000, the estimates I know from reports that I have are there's still going to be about 20,000 of the 40,000 that are working poor people. And, you know, we'll eventually get to the point where everyone has health insurance, but it's not just going to happen. It's not like in 2014 everyone's going to have insurance. It's just not going to happen. We're going to make major improvements, and I think the Affordable Care Act is one of the best things that's happened to us. But there will still be people that are going to fall through the cracks, and that's why we will continue to free clinic will in hospitals that serve uninsured and health centers and many other organizations, you know, will still be there to give care to people that need us, because if we don't, it's going to cost us anyways, because they're going to use emergency rooms and they're really not going to, you know, they're not going to be able to prevent illnesses. I just want to end with a quick story. I saw a woman last week who, she's an actress and she's been working for 25 years, but as she said to me, I work with my heart and not with my pocketbook, so she doesn't have health insurance. About a month and a half ago, she had a colonoscopy. The result came back and she has stage 3 colon cancer. If she didn't have that test, she wouldn't have known it. Now, she had surgery. She's going to have chemotherapy. She's going to have radiation. She had surgery at the hospital. She didn't have health insurance. They couldn't send someone to her home to check the dressing because she didn't have insurance. So as we talked earlier about costs and about, you know, prevention, you know, this particular person, she was grateful because a physician agreed to go to her house every day and check the dressing and check the incision and the procedure that she had done, because, you know, he knew she was uninsured. But this person, if she didn't get that test, in 2 years she'd be dead. And if she didn't get that test and it was found out later, it probably would cost more to treat her. So we have to continue to do what we're doing for everyone in our state, because everyone needs us right now. And, you know, this particular story, this person will probably get on Medicaid or get some coverage to help her through the chemotherapy and the radiation. But if she didn't have the free clinic, if she didn't have a place to go where she can get free tests and free care, she would have never known this. And this was a woman who really takes care of herself and does everything right. So, you know, I just wanted to end with that and basically say that, you know, we will continue to make our state better, and as partners, we'll continue to all work together so that, you know, and we look forward to having many of the young people in the audience that are going to enter the healthcare field or the biomedical field and be able to continue to do the work that we've started.
Thank you very much.
Thank you. Thank you.
Before you folks all disappear, I would just like to make a quick plug here. First of all, George Bernard Shaw had a very famous saying in which he said, never trust a surgeon, never give a surgeon the pecuniary interest in the cutting off of a leg. And I think one of the things that we've seen here tonight is people who represent the exact opposite of that particular perspective. It is enormously joyful to see alums of the University of Rhode Island who have such extraordinary moral and intelligent approaches to healthcare. It's just it's a wonderful thing to see and something I think we can take great pride in.
Thank you. We do.
We also owe ourselves quite a bit of congratulations, I think, for having the good sense to elect someone like Lieutenant Governor Roberts, who is obviously working with our best interest in mind. But I want to ask all of you to do something for this colloquium series. As I look around, I see a lot of empty seats. And I must tell you that given how all of us, there's absolutely no question that all of us at some point in time are going to be dealing with medical issues, whether they are our own or family members or friends or whoever they are. The fact of the matter is that an enormous part of our economy, as we know, is impacted by this. This topic, these series of speakers that these coordinators down here have put together for all of you and for the folks who may be watching online right now, it's an extraordinary collection of speakers. It's a wonderful opportunity. Do yourself, your family, your friends a favor, and next week bring someone with you, okay? Really make the effort to help us get more people in this room hearing this information. It's absolutely critical and one of the most crucial issues facing our society today. So I really hope that you'll help us to put this forward. And if you're someone who has the interest or the capability to do so, write an op-ed about it. Write a letter to the editor. Ask the Providence Journal why they're not here following the story of this extraordinary colloquium.
Wow.
So let's just push that issue. I get to say that because I'm not one of the coordinators. So thank you again to this panel tonight. They've been absolutely fabulous.